I welcome you all back to the main session. I'm sure you had very exciting and inspiring discussions, and we would now love to hear more about each group, like what each group talked about. And I asked Federica's group to start first, sharing some summarizing thoughts of the discussion. Thanks.
Sorry, was that our group, Federica?
Federica's group.
Yeah, Jean, if you want to start.
Yeah. I think, I've been sort of nominated because one of the things that I've been concerned about is that about 20 years ago, there was something called the National Service Framework for Older People for Health and Social Care in the United Kingdom. And I worked on that. We had an older people czar for I think it was maybe just England. So there was responsibility right at the top of the civil service for older people. The second principle of that national framework was to identify and combat age discrimination in health and social care. This was 20 years ago. We had a local group in Southwest Surrey, which I chaired. It was a multi-agency group: health, social care, housing, voluntary sector, service users and carers. And we actually developed posters, leaflets, training. We developed a whole day training package for our multi-agency colleagues to go on, and we got money to do that. And we worked on that probably for about 3 years. And this was happening all across the country in different areas. And then it just disappeared into a black hole. And whether that work is still going on, I suspect not, because governments change, policies change, people change at the top. And it's so annoying because I've still got all the documents and stuff that we produced, which could be of use to people. And I suspect there's pieces of work like that have been done across the board in other places, certainly people who will have worked on that national service framework, and it's just been lost. And so with this work that you're doing, there's certainly an element of, well, you're reinventing the wheel, because some of that work has already been done. And okay, you're looking at the research, and somebody in our groups, well, did you make a difference? I can't say whether we made a difference or not, because we didn't have a baseline of how much prejudice and age discrimination there was to start with. But certainly, you know, we did put quite a number of people locally went on the training, and hopefully that will have changed their attitudes to older people. And just as an aside, we work very hard to stop people using the word elderly because it's a very sort of stereotypical word with its suggestion of frailty, and use the word older people rather than elderly. And I could go on for a long time, and I'm sorry, it was mostly my contribution to the group. So if anybody else wants to add anything, you know, please go ahead.
Thank you very much, Jen. I mean, this is a really important input, and you're right. Like, there has been a research on ageism in healthcare for years, and as you say, like, I think this raises the question of how our contributions can be really long-term, or I think this is a really important point you're raising here. Thank you.
And sorry, just to say, fine, I forgot, it does need resources putting into it as well, because unless you've got the money and the resources and the willpower to actually say, yes, we are going to seriously combat this, you won't get anywhere.
That's also a good point.
If I can, Hannah, if I can just add something, I think then it would be important to share the information. So if maybe Jean or anyone can get in contact with us, and then we can so we can value this treasure of knowledge also. I think is important. Yeah.
Yeah, happy to share if I can find the box upstairs with it all in.
That would be great, really. I now ask Itai's group to share some points of discussion.
Yes, actually, I would like to represent the discussion of the group. Of course, I'll be happy if my group mates can help me out if I missed anything. I'm
sorry, but the sound is very poor. I'm sorry, we can't understand you.
Okay, sorry. Can you hear me better now?
It breaks always, Itai.
I will try this a bit louder. It works. And I'm going to try to represent no. Now.
Maybe anyone else from your group has some inputs or something to share? Somebody that was in Itai's group?
Yes.
Please.
I was in the same group. We discussed the patronizing way that doctors dealt with older people. Some people had no response whatsoever from the medical profession. Others had been patronizingly referred to. We didn't really discuss much more than the attitude towards us as older people.
Well, I would like to repeat the point I made about the medical profession being endemically ageist, because most of the research is done on young men and not on older people, not on children, and not on women.
Yes, you did. We did, Lindsay, yes.
So the drugs are tested, and you know, looking at genetics and every kind of thing, every aspect of medical care is not done on older people or on women.
From a research point of view, and also we discussed living wills and later care in life, basically, only in general terms, really.
Thank you very much. I think you raised...
We were in this group, yes. We were with...
Itai.
Is it pronounced Ite?
Yes.
Is he in Mannheim? Or is that his name? Mannheim sounds German.
It's his surname. Thank you very much for your inputs. Like, I think Itai is very happy to have your voices here. That's perfect.
Good.
And the aspects you raised, like the patronizing way that is still very common in healthcare, but also the research that excludes certain populations.
Can I make a comment about the research?
Please.
Because I'm on research ethics committees, and there has been a big move to include wider groups in particularly things like drug testing. But of course, one of the difficulties in including women is that you need to exclude women who are pregnant, and also they say, you know, who might become pregnant. So it's always a balance between including as many people as you can, but maintaining safety.
Yeah, but they don't do any research on menopausal women either.
Well, they do. I mean, I've seen research on menopausal women.
Well, there is some, but not an awful lot.
But anyway, thank you for raising both points. I think that's where we continue to work on, and this is really valuable feedback. And you all have worked in these areas, obviously, or you're all very experienced. So please get in touch if you have information to share. And I sent the email addresses of our 3 colleagues who presented. So please share whatever you have with us. We're happy to learn from your experience. I will now ask Atikur's group to share some major points of discussions, please.
Thank you, Hannah. I think Jacqueline, Christine, and Eileen, all of them contributed very nicely. They can share their experience or, about the discussion, please. Eileen, you are muted.
Atikur, you did a very good summary at the end. Why don't you just repeat it?
Yes.
Okay, thank you. So basically, we talked about our participants' experience, for what we share and what we face and what we encountered during this COVID, before COVID. So there are a couple of things came, like some of them are very much faced difficulties when the medical professionals or physicians are approaching them in terms of any kind of treatment or medication. At the same time, someone experiencing the other way around, like they have very much positive, they get very much positive expression from the physicians. And one of the main discussion point was like, if we don't think ourselves that we are active, we are capable to do that, nothing gonna change in this area, because the society has their own way of thinking about older adults. So it can be changed only if we raise our voice, if we show our ability, if we say that, okay, we are capable of doing this thing, doing all of this. So the main thing is we need to feel young. We have to think about that we are acting young, and all the comorbidities that can be related to our age, it can be overcome as well. So at the same time, some of the discussion point was like, what are the government initiatives during this COVID? So mostly the experience is negative, because the government put a bar that 60 to 70, 65 to 70 years old people are very much vulnerable, or they cannot go somewhere, they cannot come to the shopping center at this time. So these policies are really creating negative impact in the society. And the last thing I would say, there was a very much one interesting example that came from Christine, I guess. So one of the older adult, when he or she was in the ambulance, at that time the healthcare provider asked, what is the plan for what is his or her plan for end of life? So he or she is just in the ambulance, maybe for some other minor issues, but the question was something like this. So this is the, I would say this is the ultimate picture of our society. So we need to think about this. Thank you for all of the participants that I was in the breakout room, because it was really a lovely discussion. Thank you.
Thank you very much. And Giovanna, please share some major points, or one of your group, whatever you have planned.
Well, we had a really fruitful discussion. Unfortunately, we didn't have much time. So, and Sandy will tell you what we discussed.
Yeah, we talked a lot about doctors and prescribing. One of the issues that was mentioned was that as you get older, a doctor prescribes a medication and that's it forever. It's never reviewed, it's never altered, you're never taken off it. If you say, I don't think this is doing me any good, it's discounted, because how could you know what you're talking about, etc., etc. So that was highlighted as an issue. The other thing was about doctors assuming that whatever you're presenting with is being caused by the fact that you're older. And we had an example of someone with arthritis in her shoulder, so the doctor said, and she paid to go privately, and it turned out not to be arthritis at all. It was fibrosis, and with the right treatment has been significantly improved. But the health care doctor was not going to do anything about that. We talked about, yes, the research into drugs and being done on younger people in the main. Let's see, we talked about the commissioning group's 5-year plan in 2017, started by saying a major concern is the aging population and the amount of money, obviously, that's being spent on treating their health needs. Over 75s have 4 times more spent on their healthcare than younger people. So that's a major issue. Not the fact that they've got these illnesses or whatever, but the fact that it costs more money to treat them. And now they've brought a new one out in 2019 where there's no reference to age at all, but to communities. And I did express the thought that maybe now we're just a community and still an amorphous mass of I prefer to say older adults than older people, but I think, you know, it's a tricky one what you say. I also said that I recently had to see a specialist in hospital. I'm fit and healthy, energetic, plenty of energy, plenty of get up and go. And I was horrified on his letter to my GP to find that I'd been given a frailty score of 3. And when I looked, I understand there are 9 points on this frailty score. Nobody spoke to me, nobody tested me in any way whatsoever, but they made an arbitrary decision. I'm going to guess, based on my age, about how frail I am, based on my age. So that's an example of things being done really behind your back, as it were, without consulting you about it. So they're the kind of things that we've talked about in the main. I think much the same probably as other people. And of course, the government's appalling ageist attitude, generally speaking, it's across the board, but it really showed its ugly face during the pandemic, when we were all lumped together for decision making, regardless of your, I mean, older people in the eyes of the government maybe can go from 60 to 100. And you can't lump all them together any more than you could lump together 10 to 50-year-olds. So, it's not, it's totally grossly unfair.
Yeah, and in the UK, in some care homes that were given blanket DNR orders.
Can I say something? I have to confess to being a fairly recently retired doctor, and I'm finding some of what's being said quite distressing because it hasn't been my experience. But I do think, in COVID, I felt this isn't fair. I feel young, I'm active, I can go and do all these things, I can do all the immunizations, etc. But what you've got to remember is that however well you feel, as you get older, your immune system is not as good as it was. So therefore, you are more at risk of things like COVID. So by saying we shouldn't go and do things, it was actually to prevent us getting the illness. I don't think it was ageism at all, I'm afraid. It was realism.
Yeah, I would have to disagree to some extent, Janet, on that, because I do feel that there's a kind of benevolent ageism, and it's just for your own good. I think what they did was to take away our own autonomy and not allowing us to make decisions for ourselves. And they haven't done that to any other group. And I find that totally unacceptable.
No, I must confess, I agree with what Janet is trying to say. I appreciate what Janet is saying from the medical profession, and I accept that doctors never contact me, but that is not the point. We are all funded by the government to belong to a doctor's practice. Therefore, one should always receive, even if it is only a 30-second phone call, we should get feedback, and we should not be excluded from because we're on no medication. When I was younger and worked in Saudi Arabia for an American corporation, preventative medicine had a great deal importance, and I suspect that has, it will be lack of funding. I appreciate that, but again, medication should be well tested. People on medication should be included in research. But I appreciate too, it's got to be very, very costly. And there is no focus on older people. And yes, I like to think I am an older person, but I appreciate what was done on COVID completely. My 40-year-old daughter insisted that I followed the rules. I did follow the rules. Most people, most of my neighbours, many of them much older than me, did not follow the rules. I intend to see my granddaughters go to university. And there I rest my case.
Yeah, I think many of us followed the rules but chose to do it rather than being told you had to. I've got a 40-year-old daughter, and there's no way she would have taught me what to do because she knows that I would take exception to that. So I think it's each their own.
I followed, yes, but I followed my daughter's rules as well as the government's rules.
Yeah. I think the important point is you should be able to make that decision for yourself. I think that's important. And I think if you chose to do it that way, that's absolutely fine. If I chose to do it a different way, that's fine as well. But it's
I mean, I
somebody
still chose
telling
to
you
do
what.
it. I still chose to do it, yes. but she was more insistent on it than I was.
Yeah. Well, she had a vested interest.
Thank you all very much for this discussion. Like, it really shows this conflict and this, like, yeah, this conflict between safety and autonomy and health and respecting all persons in population. And we really appreciate this discussion. And I would now like to ask Abudunrin's group to share, as a last group, to share some summarizing points, and then we will, have some comments.
Thanks, Anna. I'll be the one to summarize for my group. I think it's coming at a very good time because it's almost everything has been discussed from the previous speakers. But I would like to say that in my group, it's more of a two-sided coin story rather than just one particular narrative. So I would like to start with the fact that members of my group actually raised the fact that maybe it's not about the professionals. Maybe it's just our own perception about aging or attitudes to aging. For instance, there was one of my group members who mentioned that she visited a GP and she mentioned that maybe coming to the GP was because of her old age. And then the GP, told her maybe not. That's not the case. So from that perspective, it's more of a positive perspective to the side of the healthcare delivery about aging, and that's one I would like to say. And the other one was in the case of COVID-19, that older individuals were given priorities over even essential workers like teachers. I mean, these were the positive side of the narrative that was mentioned in my group. But the other side of the coin was the same narrative that we've been listening to from the previous speakers, and that is about the view, the narrative that older individuals are looked at as a commodity rather than being part of the decision making. This paternalistic approach towards care for older individuals, loss of autonomy, loss of independence. So this was an issue that was really hammered on in the group. Concerning the negative side of healthcare delivery in terms of ageism. And then the other one that was also mentioned was putting older individuals into an homogeneous category, like it's been mentioned, like everyone in 70 years plus or 65, depending on the country, were told to shield or were tagged as vulnerable during the COVID-19 pandemic. And that is really one issue that was really mentioned in my group as really not so positive about, I mean, nothing positive, not really positive about the way health and social care is being managed in terms of the way older individuals are looked at. And so these were some of the issues that were raised, so that I don't repeat things that have been mentioned from the previous speakers. And I would like if any of my group member has any other thing to share, or if they remember any of those discussions that I have not already mentioned. Thank you.
Thank you very much, Abudunrin. Thank you all very much for sharing with us your experiences and ideas about ageism in healthcare. This was actually really inspiring for us researchers, especially the comment about we have done research 20 years ago and it's still an issue. And I think this is really calling for further working together and collaborating, and not just letting it, I don't know, letting us get silent again. We should not, I think. Also, our discussions have shown that it's not black and white, that ageism is sometimes more obvious, sometimes it's maybe more hidden and subtle. Sometimes it's not ageism, but it's maybe protection of persons or populations. And I think the presentations, but especially the discussions, or also the discussions, have really raised greater awareness about the detrimental consequences of ageism in healthcare. And we really hope to have provoked more thought, and general to have provoked thought about ageism and how to combat it. Like in the presentations, there were some examples of what is done today, and all of us are doing something today to combat ageism, and I think we can really profit from our community, I think. So I feel we should keep going and keep discussing, like this can go forever, and please get in touch with us, please stay in touch with us, write us emails or yeah. And because this is our last webinar in collaboration with the University of the Third Age, but we really hope to stay in touch with you. And please also visit our website, the Euroageism website, to see and to contact researchers directly, to share your knowledge. All in all, I really want to thank the University of the Third Age for this great collaboration. And I see that Sandy still would like to say something. Please, I hand over to you, Sandy, and I thank you for this great collaboration.
Okay, thank you, Hannah. For those of you u3a members who don't know, we have a Pushback Ageism campaign running. There's a working group of which I am the chair, and we worked with Hannah and her colleagues to get all this organised. What we're doing is to identify partners in other organisations that provide for older people in some way, and we are forming partnerships with them twofold really. One is to challenge ageism, particularly in the media, and the other is to promote positive ageing, which of course is where u3a comes in. And we for example, one of our partners is the Centre for Aging Better, who have asked us to help them to compile a toolkit to challenge ageism and so on. We have about 4 partners at the moment and still identifying more. So watch this space. If you know of any partners that you think would help us, please get in touch. You can just email Nellie and she'll pass that on to me. Or if you would like to be involved in some way, please do. We'll be more than happy to have you. So I think that's all to say just now, Hannah. So thank you very much. It's been a really interesting afternoon. Yeah. Chris.
Can I just ask Sandy? I tried to get the emails off the system of you. If I contact you, could you give us a contact number for you, and then give us the Attica and Joanna's sort of emails as well? Is that possible? Because I'm happy to. I just can't. Oh.
I mean, I'm happy to give you mine. I can't speak for anybody else. So, Nellie, you're recording this. Do you have that information? You're muted. You're muted. Can't hear you, Nellie.
Can't hear anyone.
No.
It would be good if that information could be circulated to all attendees by email.
Yeah.
Still can't hear anyone.
Yeah, I will follow up on that. I'm sure Nellie was recording this.
Yeah, I'll see what I can do about that.
Oh, there she is. There she is. Yeah.
Yeah, so I am recording. So was it the email addresses that you said you wanted?
Yes, and mine as well.
Okay, so if anyone emails, if you just email Sandy or communications@u3a.org.uk, it's my email, and then I can put you in contact with anyone else, and I can get in contact.
Eleanor, where can we pick up the recording from at some stage?
Again, if you email communications@u3a.org.uk, I can send that through to you.
Well, I asked about that some time ago, and I was told they would be made available, and I've heard nothing since.
Well, so yeah, if you email me, I can send it through to you.
And we will find your contact details on the u3a website.
Well, if you email the info@u3a.org.uk, which is on the website, we can send it through. The main email to get directly through to me is communications@u3a.org.uk.
Thank you.
Okay. Well, thank you everyone so much for coming. The discussions have been so fascinating, both today and the two previous ones we've had. And thank you so much to everyone from Euroageism. It has been really fascinating. So yeah, and thank you for everyone, all the researchers today. It's been a really fascinating conversation. So I think that is everything. So goodbye and thanks so much.
Thank you.
Thank you.
And to all concerned, thank you.
Thanks. Bye.
Thank you.